I hope now you are refreshed also. I promise you I'll make it refresh. So now we come to the recent advances and now treatment of diabetes. Okay, so till now so now we come to treatment of diabetes. We got a standard treatment of sulfonylurea, metformin, PPAR gamma receptor blocker like pioglitazone. I'll discuss this. The traditional drugs, which I'll go to discuss very shortly. If examiner will ask question on this topic, they will off 1 marks. But now I'm going to discuss recent drugs. Let's discover recent drugs which he is going to ask you. So we got new drug, newer treatment of diabetes. Newer treatment of diabetes. Recent drug. First is GIP. And GLP-1 agonist drug. Zoom करेंगे. GIP, GLP-1 agonist drug. This include injection, exenatide, and injection liraglutide. These questions came in last AIPG exam. Their latest questions are there. Question was also asked about their injection. They asked about this also. Now we got DPP-4 inhibitors. DPP-4 inhibitors, they include tablet, sitagliptin, vildagliptin. Both are tablets. This was again the question, latest question in last All India PG exam. ये भी question था. ये भी latest question था. Now we got one more, amylin agonist drug. Amylin agonist drug. This includes pramlintide. TIDE. Pramlintide. This is again injection. Got it? Now first you make the box number 8. This you make box number 8. This is a very, very important. So now, what type of question came in last All India PG exam? Which of the following is the GIP, GLP-1 agonist? The answer was exenatide, DPP-4 inhibitor, sitagliptin, amylin agonist, pramlintide. And out of these, which are the tablet? They are tablet, rest all are injection. Look, this is a injection, this injection, this is injection, this tablet. The question came in different format, and regarding sitagliptin question came in May 2015 May exam also. There was a question regarding sitagliptin also, and question was regarding exenatide also in May 2015. Fine. So now we talk about some more new drugs. And okay, some more new drugs, recent advances, newer drugs, more newer drugs. First is the colsavelum. It is a bile acid sequestrant. acid sequestrant. Then we talk about bromocriptine. We know about this drug. We know about bromocriptine. This drug we have been using for to treat Parkinsonism and to treat galactorrhea. But now you'll be very happy to know that this is a new drug for diabetes also. Now we got one more drug, and this name is not in there in Harrison latest edition also, lorcaserin. Lorcaserin. This question came in last year November PGI exam has come, and this is a prospective new questions. All are prospective new questions. Okay? But this question has already come also, and it's not given in any other book. It's again it's the anti-obesity drug. This is not given in Harrison also. Then we got one more new drug, resveratrol. This is also again anti-obesity drug. Now one more drug which has been launched in Indian market, but its name is not given in latest Harrison also. That is not given in Harrison also. That is canaflozine. Canaflozine. This is a renal glucose transport inhibitor. Beyond Harrison, but this drug has been launched in Indian market, so you will not get it in any of the book also, even Harrison also, and in pharmacology book also you will not get canaflozine. Okay. Now one more drug which has been recently about 2 months back, it has been declared approved by FDA. So this drug will not be in 19th edition Harrison also, which has not come yet. Not come, but I am telling you right now, and this drug will come in 20th edition because 19th edition is about to be launched. The new drug which will come in 20th edition, but I am telling you right now, that is new drug, prospective new question, imaglimin. Imaglimin. It's a new anti-diabetic drug, not given in Harrison. It will not be there in 19th also. Imaglimin is a new anti-diabetic drug. Okay. Now, one more. Now I'm going to discuss two special drugs. Balki, you can write down. This is the box number. This was the box number 8. Box number 9. These two, box number 9. Okay, box number 9. Now I'm going to tell you some of the newer insulins. In the newer insulins also, we talk about newer insulins. Newer insulins. Zoom करेंगे, zoom करेंगे, और zoom. Perfect. Newer insulins. Ultra short acting insulin. This include glulysin, and aspart. Ultra short acting glulysin and aspart, their injection of course. Then ultra long acting insulin. They include glargine and injection detamir. This is the box number 10. This all the 4 drugs came in last year under PG exam. Okay, that is the box number 10. Neuroinsulins. Perfect. Well, now I am going to discuss 2 special insulins. One of the, this is a new insulin not given in Harrison 18th edition also. One of the insulin is available in the Indian market, the other one is not there in Indian market, but these 2 drugs you will not find in any of the books also. The newer insulin are, first is the injection Afrezza. This drug is available in USA. Injection Afrezza. Prospective, and you will not find in any other book. Recently, it's a inhaled insulin. It is a inhaled insulin. Inhaled insulin. Inhaled insulin. Okay. You are bound to get this question this year. Inhaled insulin, not launched in Indian market yet, but soon it will introduce box number 11. And one more drug, insulin, which is there in Indian market, is injection Degludec. Injection Degludec. Injection Degludec. Degludec is there in Indian market, and it's a very long. You may even give alternate day also. It's a very long acting. You may even give alternate day also. This is the very important latest drugs. This is the box number 12. Box number 12 to remember. Degludec is an ultra long acting insulin. Okay. Well, so they are all latest drugs, recent drugs, which you will not get in any of the books also. No, none of the kunjis, what you read, Mudad Khanna Mitashi, they can't even think of. But all these are given in our book, Medicine Question Bank, so-called Medicine Essence and Medicine Mini Harrison. All these drugs are given in those in the 2 books. That's why I say that these 2 books are the ultimate books. Please bring the copy of the books to me. Okay, so they are the latest drugs that you will find nowhere else but in our books. So now we talk about the traditional drugs. Whatever drugs I discussed just now, they are all of 5 or 6 number, because examiner knows you have read only kunjis, and kunjis doesn't mention about these drugs. That's why they are 5. Now I discuss the routine drugs, which are of 1 mark only. The first routine drug include, of course, metformin. Okay, it's again this is a one drug, reduces appetite. It reduces appetite, so reduces the body weight. But prolonged use can lead to vitamin B12 deficiency. Prolonged use can lead to vitamin B12 deficiency, and it can lead to lactic acidosis. Okay. Then we have sulfonylureas, well known to you. They are insulin secretagogue. What do you mean by secretagogue? Because they hit the pancreas, they go to pancreas and they cause release of preformed insulin. Hit the insulin, they go to pancreas and they cause release of preformed insulin, sulfonylurea. Okay, but sulfonylurea are the one drug which can lead to hypoglycemia, but metformin does not lead to, they do not lead to hypoglycemia. Hypo is not a feature, hypo is a very important feature of sulfonylurea. Remember, they are the traditional drug which you have been reading from your second year onward. Okay, so we need not talk much about these drugs. Yeah. Then we have we got meglitinide, group of drug, okay, which include ripaglinide. What they do? They are also insulin secretagogue. They also go to pancreas and release insulin. That was the last year question was there, that ripaglinide should not be combined with sulfonylurea because both have the same way of action. Both have the same way of action. So meglitinide group should not be given to those patients are taking sulfonylurea, but they are short acting insulin. They are short acting drugs. So they have a special advantage in using for in case of postprandial hyperglycemia. ये क्या चीज है? What do you mean by postprandial hyperglycemia? Suppose you get one patient whose sugar before the meals is normal, but after 2 hours of eating food the sugar goes high. So we call as postprandial hyperglycemia. In those cases we need a drug which should have a short duration of action like these. So they are highly useful for postprandial hyperglycemia. Then we have glitazone. This includes pioglitazone and rosiglitazone. Pioglitazone and rosiglitazone, and I hope you are well aware, recently new thing, this drug has been banned in our country because both these drugs they lead to increased sodium and water reabsorption. So they may precipitate hypertension and congestive heart failure. Although this happened with both, but this causes more, so it has been banned in our country. And of course, they act on which receptor? They act on the PPAR gamma receptor. They act on the PPAR gamma receptors. Okay, and of course, we have one more drug, Alpha-Glucosidase inhibitors. They act at the level of GIT. So they hamper the digestion of complex sugars. So they don't let the sugar glucose form in the GIT. That's why these drugs can be given in type 1 diabetes also, other than we can give it type 2 also. But I was discussing in the morning, just before the half an hour back, that what which drug we can give in type 1 diabetes, oral drug, is alpha-glucosidase inhibitor. This was the latest question. This question came in last year on the PG exam. Which drug can be given in type 1 diabetes is alpha-glucosidase inhibitors. So they are the traditional drugs that we have been using, not much of a difficult thing for you because they are all you have been reading, quite familiar drugs. But the previous drug what I gave an all new drug for you, and for these drugs you have come to us. Routine drugs तो आप कहीं भी पढ़ लेंगे. Okay. Now what else is the latest treatment? Now they are going for pancreatic transplant. The recent treatment is pancreatic transplant. zoom करेंगे, pancreatic transplant, and the new thing, a new fashion has come up regarding bariatric surgery. Bariatric surgery. Bariatric surgery, by which they reduce the stomach volume. Bariatric surgery is given to only those patients whose BMI is more than 35. This was the latest question in this year AIMS May 2015 exam. Latest. Bariatric surgery is done when BMI is more than 35. Okay. And of course, so this is box number 13. Bariatric surgery is to reduce the stomach size. Okay. Now we talk about, there's some condition called insulin resistance. Insulin resistance, very frequently asked. Insulin resistance, we said to have resistance if requirement of insulin per day is more than 200 units per day. We call a patient as having insulin resistance if the requirement by the patient of insulin is more than 200 units. Then we call as insulin resistance, and is classically seen in very obese patient. It may be seen occur in pregnancy, in chronic renal failure, or some other condition where we may get insulin resistance. This is the box number 14. Okay, this is box number 14. So now we talk about complication of diabetes. Complication of diabetes. First of all, we talk about cardiovascular complication. Cardiovascular complication. They are 3 to 5 times more common as compared to normal population. The typical problem are coronary artery disease and peripheral vascular disease. This was the latest question. This was the latest question in the AIMS May 2015 exam, that particularly diabetes involved. Of course, it involves CAD, but it also causes peripheral vascular disease also. Okay, and in fact, diabetes is the most common cause of, write down, diabetes is the most common cause of amputation in the world next to trauma. Trauma is of course beyond doubt the first, but among in the disease, diabetes is the most common cause of amputation in the world. And I told you, MI is 3 to 5 times more common in diabetic patient. MI is 3 to 5 times more common in diabetes. Now a new thing has come up, legacy effect. Legacy effect. Also known as metabolic memory. Metabolic memory. Also known as, zoom करेंगे, zoom, yeah, also known as metabolic memory. Perfect, perfect. Thank you very much, sir. Legacy effect, LEGACY effect, so called metabolic memory. Just learn ये क्या चीज है. Just learn ये क्या चीज है. Right now you are sitting in your OPD. A patient come to you. He is an obese man, type 2 diabetes for last 10 years. So you talk to him, you try to convince. He says, doctor, if I don't control my sugar, what will happen? You say, oh, you are likely to have 3 to 5 times more common heart attack as compared to your other friends. He gets scared. Okay, doctor, from tomorrow only I will control sugar, and I'll do exercise, I'll do diet control, etc., etc. Then he asks you a question. So tomorrow onward, when I control sugar, then my chances of having heart attack will be same as my other friend who is non-diabetic? क्या मेरा भी हार्ट अटैक का लेवल वही हो जाएगा जो मेरे दूसरे दोस्त का है? Because just now you told me 5 times more common. Then you say, no, 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 it will not come to normal from tomorrow. You have disturbed your body for 10 years. And if you control for sugar for next 10 years, then only your level will go down to the normal population. Body remembers what you have to done to body. And this is known as legacy effect or metabolic memory. So you can write down. Legacy effect or metabolic memory is the concern for CVS complication in diabetes. CVS complication in diabetes is legacy effect. This is the box number 15. Box number 15. Okay. Now a new thing has come up. Widely discussed in all the conferences, and this question is going to come to you also. Effect of blood pressure control on diabetes. Effect of BP control on diabetes. Again, latest concept. The concept goes like this. Right now, we got one patient whose blood sugar is very, very high. His sugar is very high. His BP is also very high. And he goes to a diabetes specialist. Diabetes specialist control his blood sugar, but he forgets to control his blood pressure. So his diabetic complication, C for complication, will come down this much. His sugar has come down, BP not controlled, the diabetic complication, especially the macrovascular complication, especially macrovascular complication will come down little bit. We got another patient whose sugar is high, his BP is also high, and he goes to a cardiologist. Now cardiology wala person only control his blood pressure. He forgets to control his sugar. Now what will happen is complication. That means he has controlled his BP but did not control sugar. But his complication will come down drastically. Just see, sugar control, the complication came down this much. BP control, the complication came down drastically. खास करके macrovascular complication. Friends, this is the latest thing discussed in all the conferences. So what they are talking about, कि not only in a diabetic patient you have to control the sugar, but BP has to be controlled. It is seen that if you control diabetes, that is more likely to reduce microvascular complication. And if you control blood pressure, it's going to reduce macrovascular complication. Diabetes control will reduce microvascular complication, and blood pressure control will reduce macrovascular complication. So now they say in diabetic patient, drug of choice is ACEI. ACEI is drug of choice in diabetes with hypertension, because ACEI, whom करेंगे? ACEI will not only control the diabetes, but it will also control the progression of nephropathy. ACEI not only will control the blood pressure, will also reduce the progression of nephropathy. ACEI is the drug of choice. Okay. Box number 16 is ACEI. Now one more thing which is not given in any of the books, not even Harrison also. But this concept is discussed in all the conferences. You are bound to get this question in the coming year, not known to anybody, no books, no kunjis will give, that we have a drug called, there is only one ARB. ARB is angiotensin receptor blocking drug. We have only one ARB which acts on the PPAR, only one ARB which acts on the PPAR gamma receptor. We know very well that glitazone acts via PPAR gamma receptor. But recently they have come with a new drug. Tell me certain. Zoom करेंगे. Tell me certain. Is the only ARB which acts on the PPAR gamma receptor. Prospective new question you will not get anywhere, but widely discussed in all the conferences, so you are bound to get this question. Again, I am emphasizing all the new concept and new drugs which are discussed by the professors of various medical college in the big conferences, which are not given in any other books, are the hottest question they are going to ask you. So telmisartan is a new drug, only ARB, which act on the PPAR gamma receptor. Now one more new drug, it has been launched in Indian markets, but not given in any other book, including latest Harrison, जिसका नाम नहीं है. We got only one drug. We have one drug called seroglitazar. Seroglitazar. Glitazar. Seroglitazar. It's an anti-lipid drug. It acts on the P. Beauty of the drug is that it acts on the PPAR alpha and gamma receptor. It's a PPAR alpha and gamma receptor. So by gamma receptor, it reduces blood sugar, and with alpha receptor, it reduces lipid. So this one drug which reduces both lipid and the blood sugar. This drug is not given in any of the books also, no kunji, no guide, but widely discussed in all the conferences, is available in Indian market. So you are bound to get this question this year. So friends, something special about that, you got one ARB which act on the PPAR gamma receptors. We got seroglitazar which act on the PPAR alpha and gamma receptor. This is the box number 18. This is box number 18. Okay, box number 18. Now we talk about diabetes and kidney. Now you must have been very tired now. Let me refresh you. So very simple question for you. Let me refresh you. तो fresh कर दूँ आपको. बड़ा ही आसान सवाल है. You all of you know the answer. The question is, which of the following is the earliest feature of diabetic nephropathy? Which of the following is the earliest feature of diabetic nephropathy? Option A is increased GFR. Question 2, answer 2, increased kidney size. तीसरा, potassium. Fourth, micronutrient. albuminuria. बड़ा ही आसान सा सवाल है. This question come almost every year. So you can take 30 seconds to think an answer and your time starts now. 30 seconds to think. It's a very easy question. All of you know the answer and everybody has to write the answer in your copy. Everybody has to write the answer in the copy. Okay? Done it? Well, so who says the answer is A? Raise the hand. B, C, D. Yeah. Most of you are going for D answer. Yes, D is the most common wrong answer. The right answer is A. This question is done wrong by 90% people in the whole country. 90% people, because examiner knows you have read Kunjis और कुंजी में इसका आंसर डी दिया है, वो गलत है. Examiner knows you have read Kunji and the Kunji gives the answer of D. That is the wrong answer. The answer is race GFR is the first feature. Then this is the first feature. Then comes the microalbuminuria. That comes second, not the first. Got it? So friends, earliest feature is race GFR. So make a box. Earliest feature is race GFR. Earliest increased GFR. Box number 19. So all of you raise the hand, those who have done wrong or not done the answer. Raise the hand. All of you, don't feel shy. Please look around. 80-90% people commit mistake. Okay. So your friends will commit mistake. You will not commit mistake, but your friends are bound to commit mistake because they have not read from Dr. Bhatia. Got it? So you have been trained. दोस्तों, अर्जुन पैदा नहीं होते, अर्जुन बनाए जाते हैं. इस देश में अर्जुन बनने वालों की कमी नहीं है, द्रोणाचार्य नहीं मिलते हैं. तो you need to have right teacher to tell you the right direction. दोस्तों, done wrong by 90% people commit mistake. Okay? Well, one more thing. This is box 119. One more prize-winning question. And this answer is not known to anybody in the whole country. And this question comes almost every year in PGI Chandigarh. This is the category of prize-winning question are those whose answer is not known to anybody in the whole country. In diabetes, we may get hyperkalemia. In patient who has normal kidney function and he's not taking any ACI, but hyperkalemia can occur, and this is due to type 4 RTA, type 4. This is the box number 20. I hope you remember type 4 RTA. Type 4 RTA. Now we got one more new drug which is not given in latest Harrison also, and you will not get anywhere in any of the books also. We got one drug called ruboxytorine. Ruboxys. Although the word is single continuation, but I am writing you the gap because it is difficult to pronounce. Ruboxytorine. A single word is there, but I am just giving the gap for easy pronunciation. Ruboxytorine is one drug which reduces progression of nephropathy, as well as retinopathy. Box number 21. It's a one drug which reduces progression of both nephropathy as well as retinopathy. Decreased nephropathy and decreased retinopathy. Not given in Harrison 18th edition also. Okay. Now, eye involvement in diabetes. It's a one topic which is discussed in great detail by the eye specialists, our ophthalmology faculty. But all of us know that diabetes is a very common cause of blindness. In fact, in the Western countries, diabetes is the most common cause of blindness in the Western countries, because it can lead to retinopathy, it can lead to snowflake cataract, it can lead to edema in the macula also. Now, recently they have done a big trial in AIMS. Huge trial was done. They used 2 drugs and they found wonderful results in preventing or treating diabetic retinopathy. And these names are not given in the diabetic chapter of Harrison 18th edition also. But since the trial was done in AIMS, you are bound to get this question in the coming exam. The 2 drugs are bevacizumab, and the second drug is Renibizumab. Box number 22. Box 22. I hope all of you are doing the numbering. So bevacizumab and ranibizumab are the 2 drugs which they have used. They are, in fact, they are monoclonal antibodies. They are monoclonal antibodies. And they are they used to do what? Anti-angiogenesis. They are anti-angiogenesis. Anti-angiogenesis. That means they inhibit the new blood vessel formation. So they are anti-angiogenetic drugs, so they prevent the formation of new vessels. Okay, bevacizumab. And of course, you will not get it in the books also, again repeating. Now we talk about diabetic neuropathy. Diabetic neuropathy. Neuropathy is the biggest problem in diabetes. Neuropathy. NP is neuropathy. Most common is distal sensory neuropathy. Otherwise, it can lead to proximal motor neuropathy, and it can lead to paraplegia. It can lead to, in diabetes, autonomic neuropathy can occur, or cranial nerve. And the most common nerve involved is third nerve. Third nerve is the most common cranial nerve. And please remember, the unique feature about third nerve is, in diabetes, pupil are normal. Pupillary reaction is normal. People are not involved in the diabetes involving the cranial nerve. This is the latest question is there. Okay. Now, it can lead to autonomic neuropathy. Autonomic neuropathy. So what it can lead to? How patient can come to us? Patient may come with unexplained tachycardia. patient may come with postural hypotension. Very important question. It may come with diarrhea in 95% cases, constipation in 5%. The patient may come with in the GIT diarrhea in 95 or constipation in 5% cases. It may have that problem also. Urine retention. Again, due to autonomic neuropathy. Retrograde ejaculation in males. Retrograde ejaculation in males. Retrograde ejaculation in males is the problem in these patients. Okay. Altered sweating response. Altered sweating response may be altered sweating. So all these are autonomic neuropathy, and of course erectile dysfunction is a big problem again due to autonomic neuropathy. For erectile dysfunction, we use drugs like sildenafil, we use for this drug, okay, erectile dysfunction. So friends, regarding the neuropathy, autonomic neuropathy, tachycardia, postural hypotension, diarrhea 95, constipation 5, urine retention, retrograde ejaculation, altered sweating response, and erectile dysfunction के अंदर we use sildenafil. We can also use a drug called apomorphine. We can also use drug yohimbine. You can use drug apomorphine. We can use yohimbine. Okay, yohimbine. These are drugs what we are using for diabetic autonomic neuropathy. Okay. Now we have a term called diabetic painful neuropathy. Painful neuropathy, you must have seen plenty of diabetic patients. These patients come and they say, doctor, when I sleep at night, I've got lot of pains in my legs. Lot of pain. They keep on crying for pain. They are not able to sleep whole night. They will tell their servant to press the legs throughout the night, but they are really in very bad shape because they are types of neuralgic pains. And he will keep on saying, doctor, I have taken plenty of analgesic, I have taken Disprin, I have taken Combiflam, I have taken this, that, but no effect. Why? Why no effect? Because these pains are due to neuralgic pains. That's why drugs like aspirin, Combiflam do not work. Now, what drugs we can use in these patients? Drugs what we can use in these patients are carbamazepine, we can use gabapentin, we can use phenytoin, amitriptyline, but a new drug has come up. New drug has been introduced. First you note down these drugs. So painful neuropathy में carbamazepine, gabapentin, phenytoin, amitriptyline, and of course capsaicin cream. ये latest question है. But the new drug, I hope you have written this thing. Carbamazepine, gabapentin, phenytoin, amitriptyline, capsaicin cream. The new drug which has been introduced in Indian market just now, duloxetine. Duloxetine. It's a new drug for painful neuropathy. Box number 24. Box number 24. This is box number. Story. Yeah. Sorry, this is box number 23. 23. Duloxetine. Okay. I can rub it out now. Yeah. Now the question comes, how do all these diabetic complications occur, especially the chronic complication? There are various theories given for this, but one of the very important theory is polyol pathway theory. Polyol pathway theory. Polyol pathway story. How the diabetic complication occurs, especially the chronic complication. Polyol pathway theory. What is the theory is? Let's learn the basic. Let's learn the basic concept. Basic concept. So for that we have to read biochemistry. Normally glucose is converted into sorbitol. Sorbitol. And this is done by the enzyme aldose reductase. Aldose reductase. So aldose reductase convert glucose into sorbitol. And in diabetes, large amount of glucose is there, and that produces large amount of sorbitol. And sorbitol act like a tissue toxin. So it's a high amount of sorbitol which is responsible for many of the diabetic complications. And this reaction they knew for the last 50 years. For the last 50 years, they were trying to get a drug, aldose reductase inhibitor. They are trying to get aldose reductase inhibitor. They knew that the moment we get a drug, aldose reductase inhibitor, we shall be able to reduce the complication of diabetes. And recently they got a drug, and the drug is a tablet available in the Indian market, but this is not given even in latest Harrison also. So you will not find in any of the things. The name of the drug is Apalristat. Apalristat. This is a aldose reductase inhibitor. Box number 24. This is a aldose reductase inhibitor. Thereby it is going to prevent the complication of diabetes. So, okay, complication of diabetes, right? So now we move on to acute complication of diabetes. Acute complication of diabetes. And in the acute complication, the first thing we talk about is diabetes ketoacidosis. DKA. DKA is a very, very important topic. Very, very important topic. Those of my friends who are still in pre-final or final year students, DKA is a very commonly asked long question in your final prof. And regarding our MCQ, there are plenty of MCQ you will get in this in all the exam. Okay? So well, so DKA. First of all, it is more common in children as compared to adults. As compared to adults. Sugar value is in the range of around 400 to 600 milliamp percent. Sugar value are in the range of 400 to 600. But the main hallmark of the disease is the child develops nausea, vomiting, pain abdomen, marked dehydration, Dehydration is so much the tongue is like a wood, dry wood like tongue. जीभ बिल्कुल लकड़ी की तरह सूखी हुई होती है. Once you see, you will never forget. Dry wood like tongue. Okay. Then what else? Patient has metabolic acidosis, with increased anion gap, with increased anion gap, and that lead to what? Small breathing, and due to same reason you get hyperkalemia because of acidosis is there, and you get pseudo hyponatremia. Every line is a question. खास करके सर्कल करेंगे, ड्राई टंग, pseudo hyponatremia. ठीक है. सीरम अमाइलेज लेवल में भी रेस. Serum amylase level is increased. So in treatment, you give injection regular insulin intravenous. A latest question है वाला. You give regular insulin intravenous. You give normal saline and you give antibiotics to control any infection. Now what complication can occur? What complications can occur? Cerebral edema is the most dangerous complication. This is the latest question. Cerebral edema is the most dangerous complication. Zoom करेंगे सर. So injection regular insulin intravenous, normal saline, antibiotic. In the complications, cerebral edema is the most dangerous complication. Otherwise, it can lead to MI also. It can lead to acute gastric dilatation. Are some of the complications, but this is the latest question. Cerebral edema is the most dangerous complication of a case of diabetes, ketoacidosis. So you got plenty of MCQs. We are getting plenty of MCQs here also. Okay. I think I can rub it out. Now we talk about non-ketotic hyperosmolar coma. 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 This is seen in elderly people. Elderly people, to be more precise. Elderly people. Sugar values in the range of 900 to 1100 milligram per cent. Please note, DKA occurred in children, but this occurred in adults, elderly person to be more precise. And sugar value are in the range of 900 to 1100. In that case, it was just 4 to 6. Why they come late? Because here, nausea, vomiting, abdominal pain are not seen. Not seen. That's why they come late. They come with altered sensorium. Usually they come with altered sensorium. Altered sensorium and marked dehydration. Why marked dehydration? Because of osmotic diuresis. Marked dehydration. So treatment include, you have to give injection regular insulin, intravenous. You give N/2 saline. You give N/2 saline. Is a treatment that we give in non-ketotic hyperosmolar coma. One more complication of acute diabetes is lactic acidosis. Here patient come with severe metabolic acidosis with increased anion gap. Severe metabolic acidosis with increased anion gap. It is seen more in patients who are taking metformin, more in alcoholic patients, So, and this carries a very high mortality is there. So you have to give large amount of injection soda-bicarb. Large amount of soda-bicarb is to be given, to prevent that, because otherwise mortality is as high as 50 to 70% in lactic acidosis. Now, the fourth complication in acute diabetes is hypoglycemia. In fact, hypoglycemia is the most common acute complication. Hypoglycemia is the most common acute complication. Sugar value may be in the range of 40 to 60 milligram per cent. So when sugar goes down, body secretes certain counter-regulatory hormone. Okay. Now let's discuss Sumogai phenomena based on hypoglycemia. Sumogai phenomena. Sumogai phenomena. So when sugar goes down, maybe about midnight, 2-3 a.m. sugar goes down, body secretes certain counter-regulatory hormone and they bring the sugar to normal level. God is the greatest engineer. Now, at 2 a.m. or 3 a.m., sugar goes down, and the body secretes certain counter-regulatory hormone which bring the sugar to normal. Now, what are the counter-regulatory hormone? Remember, patient when the sugar goes down, patient typically complain of palpitation, sweating, घबराहट, hunger, uneasiness. लेकिन the earliest now counter-regulatory hormone are counter-regulatory hormones. Earliest is always glucagon, and soon come epinephrine. But this is the earliest, latest question. ये भी latest question है. Earliest to come is glucagon, then come the epinephrine which lead to palpitation, घबराहट, sweating. Later on, growth hormone, corticosteroid, ठीक है, and thyroid hormone, they come up, and they will bring sugar to normal at 8 a.m. in the morning. So patient come to you at 8 a.m. in the morning, he says at midnight, I had got ठंडा पसीना, घबराहट, sweating. What did you do? Doctor, I went to kitchen, मैंने पानी पी लिया, I drink cold water and then I slept. But now 8 a.m. sugar, he has not eaten anything, but sugar is high. It may be 300. ठीक है? So if you are not careful, you may increase the dose of anti-diabetic drug, which is absolutely wrong. In this case, you have to reduce the dose of insulin. So, because reduced dose, hypo will not happen, and then this will not happen. So, Sumogai phenomena is, to write down, Sumogai phenomena is 2 a.m. low sugar, 8 a.m. high sugar. This is Sumogai phenomena, box number 25. Similarly, we have a dawn phenomena. Dawn phenomena. Dawn phenomena. Here, 2 a.m. sugar is high, and 8 a.m. sugar is also very high. 2 a.m. sugar high, 8 a.m. sugar is also high. This is due to nocturnal surge of growth hormone. There is excess of growth hormone at night that lead to high sugar at 2 and high sugar at 8. Remember, 8 a.m. sugar was raised in both Sumogai phenomena as well as dawn phenomena. But if you want to differentiate between the two, you will check sugar at 2 a.m. In 2 a.m. in dawn phenomena sugar is high, but in Sumogai sugar is low. So friends, in dawn phenomena, 2 a.m. increased sugar, 8 a.m. increased sugar. This is the box number 26. This is the box number 26. Okay. Well, we have one entity called syndrome X. Syndrome X. Syndrome X. In this, the feature include type 2 diabetes, obesity, hypertension, increased triglyceride, but increased LDL is not a feature. Not a feature. This is also known as metabolic syndrome. This is also known as metabolic syndrome. So in this, increased LDL is not a feature of syndrome X. This is box number 27. Okay. So remember, in syndrome X or so-called metabolic syndrome, hypertension, obesity, type 2 diabetes, and increased triglyceride are the feature, but increased LDL is not a feature. It's a very frequently asked question. So friends, you got 27 boxes. I give you just 2 minutes. Go through all the 27 boxes. Just quickly go through. Okay. Quickly go through. Give me a stopwatch. Stopwatch. Quickly go through all the boxes. Yeah. So let me start. So I am reading the boxes for you. Let's see how much time we need. I promise you that we will revise in less than 5 minutes. And this is a box. Zoom करेंगे. Yeah. So the stopwatch is there. Zoom करेंगे. Time को दिखाएंगे. Zoom करेंगे. Focus करेंगे. Sorry. दिखाएंगे जरा. Yeah. No. इतना. नहीं था दूर. हाँ. Yeah. So I'm starting. Start. Well, box 1, HbA1c, more than 6.5% is diabetes. Estimated average glucose is based on HbA1c. Box number 3, newer types of diabetes. Acute fulminant diabetes is due to viral infection. LADA is autoimmune diabetes in adults. MODY, type 2 diabetes in children. Latent diabetes in stress-induced, and protein energy maladies diabetes is due to reduced amino acid level. Down and up regulatory receptor is seen in type 2 diabetes. Leptin is the one which reduces insulin resistance in our body. It reduces insulin resistance in our body. Thrifty gene theory is meant for overeating or obesity. Glycemic index is the ability of any food to increase the blood sugar to the fastest. Newer types of diabetes or new types of treatment, newer treatment diabetes, GIP, GLP-1 agonists are injection exenatide and liraglutide. DPP-4 inhibitor are tablet sita and vildagliptin. Amylin agonist drug is injection pramlintide. Then newer drugs include more colsavalum is a bile acid sequestrant. Bromocriptine has been approved as an anti-diabetic drug. Lorcaserin is an anti-obesity drug. Resveratrol is again an anti-obesity drug. Canaflozine is a renal glucose transport inhibitor. Imaglimin is again a new drug for diabetes. Ultra short acting are glulysin and aspart. Ultra long acting are glargine and detamir. Now we talk about box number 11. So we got injection apheresis, inhaled insulin, injection degludec, very long acting insulin you can give alternate day. The new treatment include pancreatic transplant or bariatric surgery is done when the BMI is more than 35. Insulin resistance when requirement is more than 200 units per day, seen in obesity, pregnancy and CRF. Legacy effect, so-called metabolic memory, is the serious complication in diabetes. ACEI is the drug of choice in diabetic with hypertension. Telmisartan is the one drug, only ARB, which act via PPAR gamma receptor. Box 18, semaglutide is the one drug which act on the PPAR alpha and gamma receptor, so reduces sugar and lipid. Earliest feature of diabetic nephropathy is increased GFR. In diabetes, hyperkalemia can occur due to RTA type 4. We got a drug, reboxetine, which reduces nephropathy and retinopathy. We got bevacizumab and ranibizumab, which reduce the diabetic retinopathy. Duloxetine is used to treat painful diabetic neuropathy. Apalristat is a one drug which is a aldose reductase inhibitor, so it prevents diabetic complication. Somogay phenomena is 2 a.m. sugar reduced, but 8 a.m. sugar is high. Dawn phenomena, 2 a.m. sugar is increased, 8 a.m. sugar also increased. Box 26, and the last box 27. In metabolic syndrome or syndrome X, is increased LDL is not a feature, not a feature. How much time? 4 minutes and 21 seconds. Zoom करेंगे? Yeah, 4. You can see 4 minutes 21 seconds. Yeah.